All right, so should we begin, or should we wait a few minutes, Donna, for more people to come, or people will join us as they can?
We could probably get started, I think, and let people come in slowly just for time. Thanks, Jen.
Sounds good. All right, welcome everyone to today's Alive Mental Health Research Virtual Cafe Translation Conversation. Thanks very much for joining us on a Thursday afternoon. I'm Jennifer Bibb. I'm a Senior Research Fellow within the Alive National Centre and lead of the Co-Design Living Labs network within Alive. And it's my pleasure today to start off proceedings in the absence of the co-directors, the bosses, as Matt and I call them, are not here, so we're running the show. So it's lovely to have everyone. So let's start off with acknowledging country before we hand over to what we're doing today. So just acknowledging the traditional owners of the land that we're joining from today. For myself, it's the Wurundjeri people of the Kulin Nation, and paying my respects to elders past and present, and acknowledging their continued connection to the lands and waters and skies of our beautiful country, and also recognising that wherever we are in Australia, that this land was stolen and always was and always will be Aboriginal land. And also extending that respect to the traditional owners of the lands that you're all joining from today across Australia. And feel free, if you would like to, pop in the traditional owners of the lands that you're joining from today across Australia. It's always nice to see where people are joining from. And so I'll hand over to Caroline Walters to start off with and introduce us to what we're here for today.
Thank you, Jennifer. Hello, everyone. My name's Caroline Walters, and I'm one of the co-leads of the Lived Experience Research Collective. And it's my absolute pleasure to welcome you to the Virtual Cafe Translation Conversations. And today we're looking at co-designing community support for families to strengthen mental wellbeing, examples from 2 research projects based in Australia. Thank you, Caroline, if you can move forward. So I've got the pleasure of recognising lived experience. So I'd like to recognise the lived experience within the room today, and that we speak honourably and respectfully about ongoing emotional distress, experiences of trauma and mental ill health, and the work of caring and the experiences of care within this context. And as you see on this slide, these are the Alive National Centre values and the foundations of the actions to the call, which was created in 2024. Next slide, please, Caroline. I'd just like to do a note on language. So as always, we want people to be aware that the Alive National Centre for Mental Health Research Translation spans many diverse and wide spaces of mental health, mental ill health, distress, suicide, and social and emotional well-being. We understand some might find language or framings not always what is preferred and may experience discomfort. As always, take a break, grab a cuppa, and if you need to leave the session and rejoin later, please do. Next slide, please. So if anyone is new, welcome. Just to give you a little bit of information about Alive. So our purpose is transforming mental health and wellbeing through primary care and community action. And our vision is vibrant communities that support mental health and promote wellbeing to enable people to thrive. And upon this slide, you can see that our membership is continuing to grow. And so these are the numbers of the current membership. So I'll just leave it there for a few seconds for you to have a look. Okay, Caroline, do you want to move forward, please? So just to look at what's coming up in the centre. So the next Alive National Quarterly Forum will be on Wednesday, September the 10th at 11 o'clock. This is for members only, but if you wish to join or want to come along, please contact Alive Hub at unimel.edu.au. And then we have the 2025 NGRN seed funding scheme, which will close on September the 29th. And information for that can be found on the Alive website. And if you're interested in attending some fabulous learning, you can sign up for the Integrated Lived Experience in Applied Research virtual learning studio workshops from October 14 to 16 on tackling power in negotiating co-research. Once again, any questions, email the Alive Hub. So today's talk informs the following consortium objectives. So new ways of understanding and implementing multi-level community-based early intervention and community-led models for holistic care, encompassing physical, mental, social, spiritual, and environmental well-being. So this is holistic, not in pieces or parts of things brought together, and is related to the following consensus statement. The Alive National Phase 2 Consensus Statement, which is looking at pathways of families and implementation to actions. And so it is my absolute pleasure to welcome Assistant Professor Dr. Jean Paul. So Jean Paul is a social scientist and tenure track assistant professor in participatory research in mental health research at the Medical University Innsbruck, Austria. She is originally from Melbourne and completed her interdisciplinary PhD in 2015 at MCRI and the University of Melbourne on the topic of communication between clinical geneticists, parents, and children with developmental delay receiving genomic testing. Her research bridges social science, medicine, and participatory approaches to improve mental health systems for children, parents, and families. So thank you very much, Jean, for joining us, and we are very much looking forward to your presentation.
Well, thank you very much for the kind introduction and for the opportunity to meet and talk with you today. I'm based in Austria, but very excited about the work of the Alive Network and happy to be able to exchange with you a bit and talk a bit about what I've been doing over in Austria. I'll just start with my acknowledgement of country. So I acknowledge the Wurundjeri Woi-wurrung people of the Kulin Nation, the traditional owners and true sovereigns of the land on which I am here today in Naarm. And I repay my respects to the elders past and present and to all Aboriginal and Torres Strait Islander people who also might be joining us today. I recognise the enduring care of country, culture, community, and the knowledge that's been nurtured here for more than 60,000 years, the oldest living culture. And although my current work is based in Austria, I remain grateful to be back in Naarm today and to take with me the values of connection and care that's formed in this place. And I acknowledge that sovereignty was never ceded. In addition to that, a short reflexive statement, a little bit about me. So I'm an interdisciplinary social scientist, as you heard, in participatory and collaborative approaches with a background in genetics, linguistics, and child mental health research. I'm Australian with British ancestry, and I speak English, and I have a team of Austrian and German colleagues. My values and experience influence how I interpret participant stories. So I'm passionate about working in partnership with practitioners and people with lived experience to exchange, learn, and work together towards solutions. I see analysis as an active and reflexive process, and I stay mindful of assumptions that I might have and how they shape the themes and research I develop. So I have no financial or personal interests that could unduly influence my work beyond what I've declared in my positionality. So I'm going to talk about two projects that were developed in Austria, and I'm going to focus a little bit more on the first one, and given the time, just introduce some of the broad concepts in the second. But I really want to talk about the methods and the lessons that we've learned to have this conversation with you all. So why did we focus on children of parents with a mental illness? So approximately 1 in 4 children currently lives with a parent with a mental illness worldwide. And families are likely to have less resources to support these children and their development. They might be living with more difficult circumstances and have an increased risk of developing a mental illness themselves or emotional difficulties. And they're also less likely to be identified until they're accessing treatment for themselves. However, we know that early intervention and prevention can significantly change a child's future. So not unique to Austria, around the world, often it's the case that adults might be receiving care for a mental illness. At the same time, children may or may not be receiving some kind of services in relation or separate to their parents' mental illness. Often it's the case that these services are not coordinated and they may not know about each other's services that are being delivered. As this quote from one of our early parts of the project said, I think that just asking about children and family circumstances remains the biggest challenge in this whole subject area. It's just simply too little information often there and great uncertainty in handling it and how to address it, that it's simply still difficult. So adult services are often reluctant to discuss caregiving and children with their adult patients for many different reasons. So our village project was trying to first address this problem and then create some stronger supports for families. So our vision was to build upon the existing supports for children, parents and services and bring together the healthcare, education and social systems, while also maintaining the child at the centre, developing methods to enable children to also explain and explore what their vision could be for a healthier life and in enhancing their daily life. So we first wanted to identify a sensitive screening approach to find children who might be willing to access this kind of care, and then develop a child-focused village or formal and informal support around the child. We had an international and multidisciplinary team of investigators from Australia, including Melinda Goodyear, who's known to many of us here, I'm sure, and another psychologist based in Germany, Hannah Christensen, health economist in Vienna, Ingrid Zechmeister-Koss, and Annette Bauer, health economist in London. Our work was then supported by a local team in Innsbruck, where the research is based, also coming from different disciplines and with different focuses through the project. So the project lasted for 4 years plus a little bit due to COVID, and we had children at the centre with their voices and needs being specifically addressed. We were able to make use of our interdisciplinary team, and we could draw from implementation science, realist evaluation frameworks, and symbolic interactionism. We wanted to develop an understanding of what works for whom, under which conditions, and why. And we were funded through Open Innovation in Science Principles, which was, in a simple way, trying to connect the public to research processes. So another way of explaining community research partnerships or collaborative approaches. This is an overview of our work packages, but I've mapped on different aspects that we used Open Innovation in Science or patient involvement, engagement and involvement. So during the research, we tried to consider ways that we could involve and include the people that we were working together with in a more genuine and stronger sense. I won't go through that model, but just to explain the logic of and the process that we went through. Another way of representing that is, you know, from the left here on the inform end of things, this is a much more traditional approach to research methods. And during the research, we're trying to push and nudge ourselves and our research to be more towards the empowerment end of the spectrum and to provide opportunities for people affected or living with or working with people with mental illness to take on larger roles in leadership and collaboration. So we had a patient public involvement and engagement, or a competence group, and this were 6 experts by experience who met with us monthly and gave us some feedback and a voice for patients and families through the research process. We also conducted an awareness campaign because we felt that this topic is very much not discussed in Austria, let alone the mountain region that we were working inside. And if we were going to provide a research project, we wanted also to raise the profile of different services that were already available in the region. We also wanted to provide a bit of psychoeducation and discuss different forms of mental illnesses and resources that might be available. The competence group that I mentioned also developed this story of Lion Children, which depicted children's experiences of having a parent with a mental illness, needing to be strong and brave, but acknowledging that it's a costume that you can take off. We also had some narrative videos of people with lived experience talking about being a child with parents with a mental illness or parenting themselves with a mental illness. These were also used for our training. So from our early work in Austria, we identified that current prevention or care practices insufficiently address the needs of children of parents with mental illness and their families. And there were selective services, but nothing was systematic and coordinated. We couldn't estimate the precise number of children of parents with mental illness, and parents is unknown because there's no recording of those data. And we also identified we needed to improve the care philosophy and address behaviour change. We need to coordinate and provide needs-based support for children. So we conducted a series of workshops or co-development workshops with stakeholders to design these 2 practice approaches to firstly identify families where there was a child who might need some support, and then develop this village approach, this collaborative support. And these were 6 facilitated workshops in 2018 and 2019. The outcome of these workshops were these 2 interventions, the first sensitive screening and the second the collaborative village approach. And these stepped through how we could provide a service to identify children through adult mental health services or their general practitioner, and then an invitation to be involved in a collaborative village approach where they could do a strength-based development and 3 monthly check-in of a support plan for children's formal and informal supports. The SENSE and CVA approaches are all centred around being curious and collaborative and based upon strengths, hopes, and vulnerability. And you can see some more principles there on the left of the screen. We developed a manual, which was the work of Melinda Goodyear, and that's available online, free to access in German and English. And these have practice examples with dialogue illustrations as well. We developed training which was delivered both face-to-face and online, and had a number of books and resources for the people working in our intervention to access with families. So these village facilitators, of which there were 12, were trained in this approach, and they were working directly with families, parents and children to build up this collaborative village. And we had 7 sites for recruiting families, or SENSE recruitment sites. And on the left here is a map of the region of Austria, which is mostly mountains, so quite difficult to access. And those stars are the hospitals were the main recruitment sites. We also developed methods to work with children to think about their daily lives, what tools, what things they enjoy doing, who they enjoy spending time with. And these were quite creative methods. And we also had to develop this in an online version because we started recruitment right at the time of the first COVID lockdowns. So in terms of evaluation, this was a mixed methods evaluation, and we used quantitative methods to look at the effectiveness and cost effectiveness. And I won't go into too many details, but I'm happy to talk more about those. And then in terms of qualitative methods, we were looking at the feasibility, fidelity, and acceptability from both the parents and, the practitioners, as well as the parents and children's views. The qualitative aspects were all voluntary. The quantitative aspects were a condition of receiving the treatment. So in the end, we were able to approach 96 families. So these are parents who then agreed to be approached by a village facilitator. 45 of those went through to receive the intervention. 51 were excluded, mostly because they were unwell or didn't show up or couldn't be reached. And there were further dropouts after the first baseline quantitative questionnaire. In the end, from the quantitative evaluation, we had 30 parents and 21 children complete the evaluation, and 22 parents and 17 children finished a qualitative interview. So these are quite small sample sizes, but we have a lot of rich data using both these methods, and most of the analysis of the evaluation data in the published literature or in our published work focuses on parent-reported outcomes due to the small size. So just a few things to think about from our side. There were a lot of barriers for engaging with the intervention, and we thought a lot about why that might be, and we also had some data on that from interviews with the village facilitators and also with parents. There's a lot of mental health stigma, traditional medical models and hierarchies, and strong gender norms in this region of Austria, as well as the societal beliefs around privacy and being self-sufficient, or what's acceptable in terms of help seeking. So the intervention itself focused on the child, the support with daily life and social network, but this, we think, was not always well explained to families. The referring health professionals might not see the benefit of the intervention. The parents or older children might not believe they need this kind of support, or the parents might anticipate or experience problems in other social support networks, and parents and older children might anticipate or experience problems to fit the intervention into a busy or overwhelmed time schedule. However, we can also see many facilitators for engaging with the intervention. Participants described it as quite novel, focusing on the child and supporting with the daily life. And really, this was seen to address unmet needs. They also highly appreciated the flexibility and the attitudes that were perceived by the facilitators. The first meeting happens immediately. There was no long waiting time, and the family really felt in control, and the work was on their terms. So as this mother says, I've often been wondering, why have our social workers never done this? Not a single one of them sat down with my child to talk to them for an hour. At the start of the project, we saw quite high levels of stigma in our quantitative assessments. So you can see some of these examples on the left, believing that the mental illness was their fault, avoiding talking about parental mental illness to others, believing that a mental illness can be passed on, being ashamed of their parents' mental illness, and thinking that other people might treat them differently because of their parents' mental illness. However, afterwards, and this is just one quote to give you an example, or two quotes, this mother says, I would have never thought of this, what she has, as an illness. With the village facilitator, this was the first time that I dared to think, among other things, I might be ill. And this might seem like it's potentially stigmatizing, but for this mother, she then was able to accept help for herself and for her child. In terms of mental health knowledge and communication, we also saw changes after the intervention. So at the start, almost half of the parents would like more information about their own mental illness. 3/4 would have liked to get more support in the last 6 months. Almost 3/4 thought the children knew about their parents' mental illness, and 40% knew the diagnosis, but almost 70% of children never talk with their parents about the parents' mental illness. And after the intervention, this mother said, I think this was the first time that she, her daughter, received good information about what is going on with me in my head. This 16-year-old son says, "It helped me understand exactly what was wrong with my mother." We also saw improved health knowledge, communication, and relationships. So this was based on our logic model, where we hoped that parents and children understand and accept mental illness better, children and parents develop better relationships and talk with each other more, and this would lead to children and parents finding it easier to talk about how they're feeling. So on the right, this father says, after the intervention, "The way my daughter and I now get along with each other changed. Before, we never asked each other, 'How are you?' And now that's the first thing we say. 'I'm glad you're here. How are you? What is it that you've dreamt of?' And this is because of the Village Project." We also saw changes in help seeking, as this father also discusses. This is 100% what I learned from the project and the Village facilitator, that it is possible to really, in a targeted way, look at what it needs for me and my daughter and what we want and how we want it, rather than just going here and there. So our findings suggest that the intervention we developed with our stakeholders was potentially cost effective, although I didn't show the cost effective aspects, for the groups of families who engaged with it. And it needs more collaboratively organised care to be able to support families. But it's still unclear how such approaches, which are strength-based, child-focused and personalised, can be promoted and supported in an ongoing way within this context. And we really believe that when we are conducting a problem identification or a sensing methodology, the support needs to happen hand in hand. So some takeaway messages from participants or stakeholders at our final Village event focuses around the idea of networks empowering. So as one person said, by structuring the network, people affected have been helped in two ways. They discussed visibility and supporting families to build on their strengths. People also discussed supporting children and parents, and recognise that it takes time and it's important to have conversations with the children, empowering parents to see themselves as good parents with support through their challenges. They also described that collective action works. If there is a desire, there is a way, collaboration, resources, and having the political will to drive change. They also found the Village as a source of inspiration. It showed us that building these networks can help with destigmatisation and create local community impact. So we've published many scientific publications and presented it at international conferences. As I said, we've got our practice manual in open access, and we're able to get further funding to explore this approach of using collaborative research to improve perinatal mental health. We've also developed a summary of results written with and for children and families, which is available in English and German, and some more languages coming soon. So now just to switch into the other project, so looking at children and parents, supporting new parents and infants in the perinatal period. So new parenthood is a very transitional period and has been connected with higher levels of loneliness. Many parents might experience a lack and a change in their social support. Mental illness is one of the most common complications associated with pregnancy. So this is approximately 1 in 5 and up to 1 in 10 fathers up to 1 year after birth. Without treatment, perinatal mental illness can have significant short and long-term adverse effects on not only the mother and the father and the child, but also wider society. Substantial and robust evidence exists to support early intervention and prevention for new parents and infants. There is significant evidence for long-term cost benefits from the London School of Economics, so public sector costs and improvements in child quality of life. Many cases of perinatal mental illness go undetected, largely due to the stigma that parents are less likely to seek treatment or ask for help from their friends and family. Also, in relation to awareness and not recognizing that what they're experiencing might be helpful to get some help if they would like it. So this topic or this research project came about from a community-based question. So I'll just read this quote here on the left. When I was halfway strong again, I went to Jean and I said, something's happened to me. I have to tell you this. You're the one where I think maybe you can make a difference. And that's how this whole thing came about. I went to her and I said, please help me. We have to do something to change that. And out of courage and desperation, because I didn't know who else I could turn to, I thought to myself, well, I'll just see if I'm lucky. And as you can see, I was lucky. So we applied for a grant together with the head of the psychiatry department, who also wanted to make improvements on the care system of perinatal mental health, and a mother and a director of a social organisation. And we were successful in receiving this funding, which is lasting until 2027. So it started in 2022. In this project, this is now a local project with the funding restrictions of needing to keep the money inside Austria. And we have, again, Ingrid Zechmeister-Kost in Vienna, as well as two psychiatrists, Astrid Lamper and Christine Hertnagel, and an attachment-based psychologist, Anna Bruckheim. Again, we have a team who supports our work, and also with different backgrounds in psychology and sociology. As part of the funding conditions, we had to firstly design workshops to further refine the funding protocol. And we identified these 3 areas of research prioritization. So all our work should be looking at how we can improve access, gaps in care, and early identification. And you can see some of the aspects that are mostly discussed within those areas. Again, we're able to draw from our interdisciplinary backgrounds, and we really want to understand what works for whom, under which conditions, and why. So not a traditional randomized control trial that's looking only at the outcome, but really looking at the mechanisms that might lead to change and the actions behind those mechanisms. And again, using open innovation in science principles. As with the Village Project, we're continually looking to see how we can move the ball to be more focused on empowering people with lived experience and partners, people that we work with, to be more engaged in the research process. As an overview, we started with local, national, and international situation analysis. And then we worked together with our stakeholders to prioritise gaps and develop concepts. And we developed 3 concepts to make some improvements in the perinatal and infant mental health care pathway in this region of Austria. At the moment, we're coming towards the final implementation and evaluation alongside this and the delivery of these interventions. So as a short summary of the results we had from the start of the projects, we found regional disparities and no national standards and no care pathways for perinatal and infant mental health care. The biggest gaps we saw were in prevention and early detection. There's no national screening program, and it's unclear what happens if there has been a case of perinatal mental illness detected. There's no special treatment. So across Austria, there's no specialised training for psychiatrists, and there are some professional groups that are not available, maternal child health nurses or perinatal mental health midwives, for example. Mother-baby units, there are none in the state that I'm based in Tyrol. The international recommendations have, it should be approximately 32 beds that exist in Austria based on the number of births. Currently, there's no health policy priority for parents and new parents with mental illness. And so we could say that individual suffering and high societal costs are accepted by our country. So we conducted qualitative interviews. The first set of interviews gave us an idea of the historical context of perinatal and infant mental health services. And the second set of interviews showed us the current situation in Tyrol. The second interviews included participants who were midwives, pediatricians, psychologists, educational therapists, psychiatrists, gynecologists, as well as mothers and fathers, and professionals were from hospitals or private practice, community support organisations, and we conducted a mix of thematic, of inductive and deductive analysis. So the perception of pregnancy, childbirth, and childhood and motherhood has all changed over the last 100 years. Particularly in Europe, this used to be a story of survival, and this has now moved, support for women and people having babies has moved from the extended family and community and church to much more immediate family and formal services. As this person describes, in Tyrol in particular, there was a dominance of conservative family images, a need to regulate deviating lifestyles. For example, single women or families that did not correspond to the image of traditional family constellations. These were, for example, characteristics that very quickly brought authorities, in the case of youth welfare officers, up into the picture. Up until the 1980s, it was the case, for example, that a youth welfare office automatically transferred or assumed guardianship of a child born out of wedlock. Austria is a Catholic country, and the region that we're in Tyrol, is highly conservative. Additionally, the perception of mental illness has changed. So participants described that it's become more acceptable to experience mental distress, but at the same time, that's put pressure on perfection and being mentally healthy. The baby tests were the first classification system of baby depression in the world, and this was in Vienna, and it led to the work of Renee Spitz, who emigrated to Michigan during the Second World War. So as this quote says, on the one hand, it's become acceptable to see oneself as ill, to have a disease, and on the other hand, I think it's a particular challenge because you can or you should do something about it to avoid it, prevent it. The field of perinatal and infant mental health care has been extremely impacted by the Second World War in Austria, with many Jewish specialists, especially those with who were psychotherapists or psychoanalysts, leaving to America or the United Kingdom. In the Nazi era, there is a great primal fear for the care of the human being. So it's like, I'm not crazy. For people who lived during that time, a great threat. If you are somehow psychiatrically ill, that you are locked away and ultimately killed. There's also a history of experimentation and exploitation within institutions. So this has led and continues to, as what we can continue to see as a fear of institutions and a fear of psychiatry. So the contemporary situation, in terms of the social context, there's the perception that society has very high expectations for a perfect pregnancy, perfect birth, and adjustment for parents and their new baby. There's very high stigma and traditional roles and the expectations that mothers are the primary caregivers and responsible for infant development. Fathers are rarely addressed by services. So as this mother says, well, because you have to be happy. Nowadays, a lot of things are prescribed as how things should be. So a lot of things are prescribed for you and how you have to be. And especially during pregnancy and birth, there is a lot more predefined. And I think you don't dare to be different. So not happy, you just don't dare to be overwhelmed. You don't dare to be sad. And of course, it also shakes the relationships to its foundations, I think, because of shame and out of social guidelines and shame. And this participant says, in general, what the women see, they want to be happy pregnant women. They imagine it all quite nicely. They hope for a beautiful birth. They think a baby sleeps a lot, a baby never cries, I can breastfeed well, all the expectations that women simply have. They want to be perfect mothers, perfect housewives for their partner, and of course, always neatly dressed. And that's the ideal image that women have then, which no longer corresponds to reality today. In terms of screening, participants stress the importance of routinely discussing psychosocial topics with parents pre-birth. However, they acknowledge that it's difficult, often due to time, resources, and knowledge of where they could send parents who might need further support. They also particularly stress that fathers should also be screened. In terms of treatment, participants discussed a lack of clear referral pathway and low threshold support, especially gaps in free care and mother-baby units, specialist psychiatry, and access to psychotherapy. They also discussed having more confidence in making referrals when they'd had a positive experience with mental health specialists in the past. So many professionals were reluctant to send their patients to psychiatry and sought other options where the mother can stay with their baby. Some parents experienced insensitive services where their situation was minimized and their fear of medication was heightened, which reinforced the stigma and traditional gender norms and the view that psychiatry only provides medication and should be used as a last resort. Participants and providers also spoke about peer support and community organisations as being able to normalise the experience and being incredibly helpful in their recovery. So we then conducted workshops based on the results of our international and local situation analysis. And the main goal was to collaboratively prioritise an intervention that could meet the needs of the local context and is also feasible within the scope of the research project. We brought together experts from different backgrounds, and we again had these aspects that we needed to keep in mind: the collaboration of networks and care, early identification of parents with perinatal mental illness, addressing gaps in care of mother-baby beds, and raising awareness within society and politics of the importance of the topic. And we came up with 4 concepts. The first 2 are the main ones that we're going to be implementing in the next 6 months. So we're going to establish a roundtable to coordinate care for affected families, bringing together people and people living with mental illness in the perinatal period, and also those working in that field to have a regular exchange. We're also going to deliver 2 awareness campaigns using creative methodologies to improve sensitivity and discussion around mental health. And the other 2 topics I won't discuss because of time, but we also have some plans around those topics. I just wanted to finish with some takeaway messages before we discuss together. So from our experience, and I'm sure your experience as well, co-design can transform research into action. And working with these groups and working collaboratively can really ensure that our research is relevant, feasible, and meaningful. Including children's voices is important and takes time and consideration, but also helps address children's rights and making sure that services can be constructed in a way that also values their agency and their preferences. Using international evidence and local context in combination is something that we're really passionate about in terms of trying to address local services and improve care. And this also leads into bridging research and practice and participatory approaches, being able to directly inform services and clinical pathways. We can use these approaches to create sustainable impact, but I think also to finish on, we need to be very considerate of tensions when we're working in areas where there's a high unmet need for community mental health and delivering a research project. We need to be aware of how we can manage those expectations and tensions. So I'd just like to finish there and say thank you.
Thanks very much, Jean, for a wonderful presentation. Some really impressive work and kind of really interesting cultural context that you're working in as well, in terms of how local conditions are really impacting on kind of delivery and receipt of care and services. I thought it was a really interesting kind of overview. Now we've got 15 minutes for questions.